Good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida, for Larkin Hospital TV. Today on the Neurosurgical channel, we have a show with Richard Mendel MD, a spinal neurosurgeon from Tampa, Florida. He's going to be talking about low back pain, and we have a distinguished group of panelists. First, we'll introduce the panelists, and then we'll turn it over to Richard. Why don't we start with you, Bernardo? Hello, Bernardo. Can you introduce yourself, please?
Good afternoon. My name is Bernardo de Andrada. I'm neurosurgeon from Rio de Janeiro, Brazil, and thank you everyone to inviting me.
It's good to have you, Bernardo. And Jesse? You gotta unmute yourself, Jesse.
Hello, everyone. I'm Jesse Contra. I'm a graduate student in Philadelphia, Pennsylvania.
Thank you for coming, Jesse. Lisa?
Hi, everyone. I'm Lisa Cornforth from Bentonville, Arkansas, and I'm an MD student at Oceana.
Thanks for coming, Lisa. And Sajish?
Hello, everybody. My name is Sajish Kyriakos. I'm a maxillofacial head and neck surgeon, and I'm coming from Miami, Florida. I also do I'm an adjunct faculty in Larkin's, and I teach neuroscience and neuroanatomy. Thanks for having me.
Yes, Sajish is going to open the head and neck channel soon. And Simon, my main man.
Hello, everyone. Great to be back here. I'm a developmental psychologist and medical student studying in Tokyo, Japan. Looking forward to this presentation.
Welcome, Simon, and Ben stepped away. So Richard, we'll turn it over, and I'm Dr. John Bennett, the webmaster of Larkin Medical TV. And Richard, it's all yours.
Okay. Hi, everybody. After last week's talk, we discussed maybe talking about back pain. So on the topic of back pain, there's a couple of key, I think, very good references. The first two references are from Nikolai Bogduk and his whole group in Australia, and those two books are The Biomechanics of Back Pain, and the other is The Clinical Anatomy of the Lumbar Spine and Sacrum. And these are really good. These are not surgeons. These are anatomists and physiologists, and their explanations and the biomechanics are really very, very well worded, and the line drawings are very good. Clinically, Dan Resnick at the University of Wisconsin wrote a book several years ago on low back pain and its treatment, and the thing that's important about back pain is that virtually any kind of doctor you're going to see back pain. So in the industrialized world, especially in the 80s, Bogduk would say that 90% of people in the industrialized world would have back pain that would be so severe that they'd at least lose 2 weeks worth of work in their adult lifetime. And he said that people in less industrialized countries were actually like 70% chance of decreased back pain. But now, with the increase in industrialization and everything being so global, back pain is a worldwide problem epidemiologically. So back pain is the second most common cause of presentations to a primary care doctor. And in 2004, I think it was, I have some slides here. One is from Bangladesh, from the Department of Orthopedics and Traumatology, Dr. Shahid Shawardi, and I used his slides. I got them off of SlideShare earlier, and one of the remarks in the slide presentation was that in 2004, back pain was the second leading cause of visits to a doctor back pain was the third leading cause of surgery. We'll have to talk about that in a minute. And back pain was the fifth largest reason for hospitalization at the time. So last week somebody said, well, let's talk about surgical indications for back pain. The only really surgical indication for back pain that there is, that's not arguable, is dissecting an aortic aneurysm. I mean, other than that, back pain, operating on back pain itself is not at all successful. Now, if it's back pain associated with instability, like a fracture, trauma, tumor, then you can get some positive results. But the routine notion of just back pain which is isolated to the back with no radicular pain is unlikely to yield a very good result at all. So there's really, for back pain itself and spine, there's no, back pain's not an indication to operate. It is an indication if someone's got excruciating pain and they've got a dissecting aneurysm, well, that's surgical. But very little else is surgically going to address back pain. There has to be some other caveat there, like instability from trauma, tumor, and so that's a very small percentage of the patients you're going to see. And I think that's part of the reason that, you know, physicians get so tired of seeing back pain, because the really significant types of back pain that are going to require attention, you can kind of forget about when you hear, oh, you've got another back pain patient to see. You still have to look into the history, how long it's been going on, and, you know, the excruciating sudden onset back pain of an aortic aneurysm is, you have to keep in the back of your mind. And I know Dr. Bennett is an ER doctor, and you people that are internists know this, but operating for even a lumbar disc herniation, if you've got back pain and no radicular pain, you're oftentimes not going to get relief. You know, a disc, you've got a lot of discs in your spine, and it's not unusual to have enough wear and tear on those discs that you're going to have tears in the annular fibers, disc bulges, herniations. Not all of them need surgery. You know, it's part of the natural aging that you see the discs change a great deal over time. Let me see.
Excuse me. Yeah. Okay. But you change it. Okay. You can change. Okay. Okay.
Yeah. So here he is speaking about the more common day-to-day problems that trigger back pain, and that's overuse, muscle strain, injury to the muscles, ligaments, and a change in the balance of the spine and the balance of the musculature. And basically, that's low back pain. And the routine treatment of low back pain really is decreasing your level of activity in terms of, you know, twisting and axial movements, but not bed rest. You know, we've proven over and over again that patients that go and have 10 days or 2 weeks of bed rest, you tend to get much worse, and nobody can afford it anyway these days. Multi-million-dollar athletes on TV will get an injury, they'll get an x-ray, they may have a spinous process fracture, they may have whatever, but they're up and around within 24 to 48 hours, because otherwise you just get too deconditioned, and you're really not doing much other than losing muscle bulk by laying in bed. Non-steroidals and movement, but obviously decreased strain and trauma to the back. Here are some of the causes he listed of low back pain, and the thing is, you know, there are so many things you have to rule out that it gets kind of boring, but you know, you have to rule these things out. You have spinal arthritides, joint arthritides. You can have ankylosing spondylitis. A big problem in patients is, or it used to be, discitis. Discitis was kind of hard to visualize in the pre-MRI era. And now with discitis, disc will light up, if there's an infection or a transient inflammation of the disc space. And then you have to follow people and make sure that they don't have some type of bacteremia which caused the discitis. Then the discitis goes on to slowly and indolently develop into a vertebral abscess, which is extremely common in IV drug users. And you have to remember that endocarditis is often a precursor to the development of back pain via infection. So you always have to keep your infection in the back of your mind, because discitis and osteomyelitis can be really very painful. And you can also see TB, but TB is like the very reverse. It's kind of very reversed from osteomyelitis. With discitis, you get an infection in the disc, and it can spread through the end plates into the adjacent vertebral body, okay? But with TB, TB does not affect the disc. With TB, you'll see, vertebral body involvement, but the disc and the end plates will be respected. When you see that, you have to think about TB. Let's see. I'm trying to recall. A lot of the students from India that were at Queen Square really were attuned to sarcoid problems as well, but I can't really remember what I don't really remember what they used to look for. Paget's disease, failed back surgery syndrome. Then you have a lot of people with asthma, or who are dependent on steroids, or people that get frequent steroid injections, which they shouldn't be, especially diabetics. All these things come into play. Now, I can't, this is a take-home point to all the non-spine surgeons. Operating for back pain is really not very defensible at all. You won't find any good hard data in the absence of instability that back pain gets treated effectively with surgery. Back pain, the vast majority of time, especially if it's not from an infection, tumor, malignancy, gets better almost all the time. And when I say almost, I mean 90% of the time, because the guy from Dartmouth, he's very big into, I'll think of his name, but the point is that 6% of people with back pain where it develops in an industrial setting and in a work setting, 6% of those 100% go on to be completely disabled from their back pain. And when you see that, and this, I'm not saying this to be facetious. I mean, I know back pain's a terrible problem, but you have to remember that, at least in America and in the industrial world in America with workman's compensation, that if 6% of people that are working in an industry and they don't have a skin in the game are completely disabled, you have to also look at the opposite population, which would be, self-employed farmers. And I assure you that not 6% of them are going to be totally disabled. So you have to remember that when we're talking about complete disability and surgery, you're talking about a very small piece of that giant pyramid of back pain. and Dan Resnick goes into a lot of detail in his book. And the book's about maybe 10 years old now, but it was very good. Now, let me see if I can blow this up a little for you. I'm not sure.
Okay.
Let me enlarge the screen a minute.
Oh, okay. I don't know. Hope this works.
No.
Okay. You went to another screen now. Yeah.
All right.
Okay.
Well, okay. So with back pain that you're seeing kind of de novo, you got to keep in mind what are the medical problems, what are the psychosocial problems, what are the occupational indications. One of the things you really want to try to discern from the patient is whether or not they somaticize or not. In the 90s, the best test we had for people with really significant low back pain was a Minnesota multi-personality index test, MMPI. But insurance companies stopped paying for it because they thought it cost a lot. But when you think about it, it's very, very inexpensive to an unnecessary surgery, because there's a high correlation with somatization and failed back surgery or unsuccessful back surgery. So here are some of your data, and this is about right no matter worldwide. Lumbar is the major cause of low back pain. You'll have some people that'll have some isolated neck involved, but a lot of times people have neck and back pain, and unfortunately they'll come in and they'll have a thoracic MRI, and I virtually maybe see one thoracic MRI with significant findings on it a year when it comes to low back pain. You really want to focus on the lumbar and cervical spine, because those are the mobile segments of the spine. With the thoracic spine, you're talking about a spine that's immobilized by the ribs and the chest wall. There's very little movement there, and that's why there's not all that much degeneration in the thoracic spine. So I think that a plain X-ray of the thoracic spine is often fine, and it's rare that I need to see any thoracic spine when we're just talking about routine back pain, without any other kind of red flags. The other part of this talk that's important is it's the simple things you have to use for treating low back pain. You don't need to image every patient that has low back pain initially. If the pain is, controlled, they're on anti-inflammatories, I really don't think that sending them for an MRI immediately is the thing to do. Plain X-rays is probably fine, and oftentimes these people do get better over time. But people are reluctant because of how litigious things are, that they order an MRI on everybody. But it's usually not something that needs to be acted upon. When you examine these people, you have to look at them. You have to also palpate the spine. And Todd Albert and Alex Vaccaro from the Rothman Institute, where Alex is now there, but is the boss there, but Dr. Albert's boss at Hospital for Special Surgery. They wrote a book called The Examination of the Spine. It's a nice short book, but it's important to really palpate the low back and to have the patient go through a range of motion for you and see if you can localize anything about the pain. And you also want to visualize their back. You want to know if you want to keep things in mind, like things that'll give you a clue to something like von Recklinghausen's, or tracts, dermal tracts in the skin that may indicate they have the spina bifida, but that's going to be a small percentage of patients. So what are the things in the back that can hurt? Well, everybody kind of talks about like discogenic low back pain, and that's kind of rare. Discogenic low back pain is pain that you can clearly associate with one disc or one problem within the disc, and that's not usually that possible unless it's just an abrupt herniation. In an older person or somebody that's already got a lot of degenerative disease, soft disc herniations become less and less prevalent as you age, and you tend to see more in the way of osteophytic problems and bony problems and compression problems rather than soft disc herniation. And to prove that somebody really has discogenic low back pain, many people depend on the discogram itself, and the discogram itself is a whole big controversial issue that dates back to the 1940s, believe it or not. The other thing that can happen with aging is you see changes in the posterior elements, the facet joints. You may get also distracted by people that will have a pars defect. The pars is just let me show you a better diagram, but the pars is just that portion of the body. It's the neck of the Scotty dog of the x-ray. Pars defects aren't that uncommon and don't necessarily need to be blamed for the low back pain. There was a time where a lot of people were ordering radionucleotide stress tests to look at the pars defects, but I think at this point you can often determine if the pars is the problem by specific injections, and I don't see that much anymore. As far as the management of low back pain, there's a lot of controversies. There's a fellow in Jupiter, Florida, Michael Reed. And Mike is a smart guy who's a physical therapist with a doctorate, a PhD in physical therapy. And Mike does a lot with the North American Spine Society. And there are a lot of protocols that NAS works on in terms of making guidelines for evaluations and treatment. And one of the recent examination techniques was, and it won the paper that year, was on testing a directional component of back pain. And a lot of people have pitched into this, not so much the surgeons as the therapists and the rehab people, the physiatry people, so that the idea isn't that it's just going to be muscle pain or disc or pain from the disc. It could be from a joint. You can have small nerves that come off the ventral rami that innervate the disc. So it can be somewhat difficult to localize the pain as crisply as the anatomy books show it. You get dermatomal, sclerotomal, myotomal involvement, and when people are really hurting, you'll say, where does it hurt? And they really can't. They don't know the anatomy that way well. They just know they hurt, and it can be a little frustrating because if you're going to treat something, you've got to pin it down. If you're talking about a generalized pain, it's unlikely that imaging is really going to give you the answer immediately. The immediate primary triage of low back pain is not something that requires a diagnosis. What it needs is a rule out. You need to rule out a lot of bad things, and if you don't have a diagnosis such as strain or whatever, at least you know that the patient's very, very likely to improve with time, and they don't have there's no impending doom there. What else would you like to talk about when it comes to the back pain? I mean, there are lots of people that have different philosophies on exercise regimens. The group out of Syracuse, the McKenzie exercise program, people that believe in the McKenzie program, people who don't believe in extension exercises. I mean, so many people have looked at back pain, and we've met with so little success. I think it's just, you know, especially L4-5, I think it's an area that's just really prone to stress and strain. Any other thoughts? Oh boy. Anybody there?
Yes, I have a question.
Yeah.
What are some causes of thoracic pain?
Well, that's a good question. Thoracic pain, let me give you an example. If you look at the number of thoracic spine MRIs now done, it's mind-boggling, but it used to be that in the early 80s, 0.3% of all disc herniations were thoracic disc herniations. Then with the MRI era, the number of thoracic disc herniations have increased like tremendously, but it's just because we're screening an area that doesn't often need to be so carefully screened with such a sensitive test. When you look at like a plain X-ray and you examine the pedicles is where you worry about cancer, and you see an eroded pedicle or an owl sign, like a blinking owl. That's when you have to worry about getting MRIs of the thoracic spine. But thoracic spine pain itself, there are two types. There are many types, but you know, the thoracic dermatome is just a cylinder around your ribs, right? And so it should wrap from that spinal root, exit at the spine, circularly around both sides of your rib cage, and end in the front of your chest, in the sternum or somewhere like that. You have to remember that, you know, T10, the level of T10 is your umbilicus. So when you worry about thoracic radicular pain, you want to really think about that component of pain involving just a single root, which will be very much like shingles, and you also want to consider shingles in that diagnosis. Now, in terms of thoracic pain, you know, chest pain is thoracic pain. So very recently I saw a patient, and the patient was complaining a lot of chest pain, but the problem was the patient had had a heart transplant. So you know what that means. Shouldn't be generating any ischemic pain. And what he had was a dissecting aneurysm. So that's another, so you gotta think about chest pain. Chest pain is one of your things within the subsection of thoracic pain. You know, the other things that you want to think about is that gallbladder disease can often give you right subscapular pain as well. The more pain things you see, you'll see the wider your differential gets. But those are the things you want to rule out from a acute pain kind of presentation. I will tell you that with infection like discitis or osteomyelitis, you will have no problem recognizing those people. When I was a medical student, dumb as could be, my neurosurgery resident, Alan, introduced me to Mr. Asnavourian. He was a very nice, polite man who was just writhing around in bed. And he was clearly not a fragile person. He was clearly a stoic guy who was, I mean, if you would even bump the bed, he was in agony. And I just remember one of the other residents, not Alan, but one of the other residents, Mr. Asnavourian, is a peaceful, small man, wanted to kill that guy because he questioned whether or not he was, you know, somaticizing.
Right.
Osteomyelitis and discitis is incredibly painful. Really, the instability associated with that is bad.
So one quick comment, Richard. Thank you very much for a very clear presentation, nice slides. I'd like to direct this question to Bernardo, who is a Brazilian neurosurgeon. Bernardo, are your indications for surgery as narrow, surprisingly narrow to me, narrow as what Richard said, that to operate you should have radiculopathy? Is that correct, Richard? Radiculopathy, correct?
Yeah, you don't want to isolate on back pain alone. You have to have a cause, a pathophysiologic cause. You can't just operate on like something that Ben Gay is going to fix.
Well, is it the same? Is it the same in Brazil, Bernardo? That to operate on back pain, that you should have other signs other than the pain? Is it the same down there?
Hello, everyone. Congratulations for the presentation, Mr. Richards, and I agree with everything that you said. I think that the biomechanical of the spine and knowing the pathophysiology of the low back pain is very important to indicate the correct indication of the spine surgery, because the patient, you should achieve the relief of pain. So I indicate the surgery when the patient has a neurological deficit or signs of instability. I particularly like of dynamic lumbar X-ray, and X-ray in flexion and extension, and you can see the signs of instability on this exam. And I like of the MRI on T2. You can see the modifications of the end plate, and this is signs of micro instability. So I use these two criteria to indicate the lumbar spine surgery.
Okay, Richard, you want to comment on that?
Yeah, I couldn't agree more. I mean, you have to, the reason spine surgery had such awful results 20 and 30 years ago for non-trauma was we didn't have great imaging. And you had people that were adventurous that would explore one level, the other level, and that kind of, that kind of unselective criteria ends up with bad results. So you've got to see something on X-ray. You've got to prove to yourself that something's really wrong, because you should be getting good clinical results. If you're operating on everybody with back pain, you're going to have a high percentage of people that aren't doing that well. And what Bernardo said was very right, and I didn't mention it in the talk, but with back pain, there's so many different things to look at that we often think of the disc as just this slab of cartilage. Charlie Ray was a neurosurgeon, a wonderful guy who died a few years ago. But Dr. Ray used to talk about the physiology of the disc, and the disc actually has a pumping mechanism in it that's hydrostatic, and it's really complicated anatomy. And it turns out that the in patients with low back pain, you will often see lactate levels in the middle of the disc that are 8 times higher than what's in your serum. And you can also see a great deal in the way of hydration outside in the annulus fibrosus and the nucleus pulposus. The inside may bear no resemblance to the characteristics of the annulus. So, you know, if you wanted to throw away all the selectivity, you could operate on almost everybody in their life, you know, for back pain. It's just not going to have a good result, and it's going to cost a fortune.
You know, Richard, it's one of the most common operations besides hernia, gallbladder, and appendectomy, correct, in the United States?
Well, thank God I wouldn't say that. It is very common to have an operation, quote, for back pain, but really those aren't. What they're saying is that a surgery took place in the low back and the patient had back pain, but the indication wasn't just, I twisted and hurt myself. The indication was hopefully a ruptured disc or something else that was pathophysiologically wrong, because, you know, that's a tremendously high number of people getting operated on, but that's true. And that's why our healthcare system is bankrupt.
Oh, okay. Before we go on, Richard, just click on your screen share to get off it. So
screen share?
Yeah, just get off it. Just click on the
thing.
Yeah, click on the arrow, on the green arrow, to get off the screen share, so that we can see your beautiful face. Okay.
Excuse me.
Go ahead, Simon. Go ahead, Bernardo. I'm sorry.
Well, of course, the patients who you can indicate the surgery, the pain should be refractory to the conservative treatment. This is another criteria that we use. If you have the refractory pain or a neurological deficit, refractory to the conservative management, or neurological deficits and signs of instability, I think the patients can has the pain relief with the surgery.
Oh yeah, I think that goes without saying. The problem is here that people want instant gratification. They don't want to exercise. They don't want to do anything to help themselves. They just want surgery, have it fixed, and go home. And that's not, that's just not the way it works. You got to have refractory pain, and you have to have failed conservative management, or your results just aren't going to be what you had hoped.
I think Simon has a question. Go ahead, Simon.
Yes, please. Nice, thank you, Dr. Mendel. My question is regarding a compression fracture of the lumbar spine. When I was 18, I had a surfing accident, and I fell down on the sand and sat down straight up on my tailbone, and I went to the doctor, and I had some numbness for about a year, and I actually couldn't sit down for a year. It sounds strange, but I really couldn't sit down. I had to stand up a lot, and when I did lie down, even I had to bend my knees with a pillow. Yeah. I was wondering, since the 1980s, yes, sorry?
Yeah, when you bend your knees with a pillow, that flattens your back out. Yeah.
And it helps a lot. Yeah. And I was wondering, has the treatment changed? Because at that time they said there's nothing they could do for me.
I don't know whether it's fortunate or it's unfortunate, but yeah, it did change a lot, and it's not necessarily for the better. It's extremely profitable now, but it's not necessarily good. There were 2 fractures that were never treated for the last 200 years in medicine. One was the linear skull fracture, and the other one was compression fractures of the spine. But some people did some innovative things. The first person was in France in the late 80s, early 90s. And then a fellow in California and somebody from the Cleveland Clinic, Dr. Isidore Lieberman, they introduced a product to market called kyphoplasty. And so compression fractures were treated with kyphoplasties there was an explosion of treatment for compression fractures. And what we kind of learned in a nutshell is that if you can get a little methyl methacrylate across the fracture, often the acute pain is much better. And the people it helps are not you, Simon. It's the older patient with osteoporotic compression fractures. What we found was that in trauma, we really didn't make many people that much symptomatically better. So it tended to be more in the people with weaker bone. The problem with the compression fractures is that if you treat everyone via this kyphoplasty, it's really, really expensive, and you don't really have a lot of data to prove that it's worth it. I think you reserve that for the people that really are in bad pain, because you have to remember the older patients, especially the thin, frail women, they can't wear, bracing doesn't work very well. The brace rides up on their hips, doesn't immobilize them. So in a way, it makes some people more comfortable immediately, but not everybody. So you would use it selectively. But for trauma, I wouldn't have recommended it for you.
Thank you. Yeah, okay. But it was certainly very, very uncomfortable for a year. Really?
Yeah. One question, Richard, and it's actually directed to the other doctors on the panel and to Bernardo. One of the banes of an ER doc, like I was for a while, is the drug seeker that has back pain. I want to know from you and Bernardo what kind of things you do to screen a person from that really does have back pain to one that's feigning back pain in order to get narcotics. I know it's not easy, but is there any tricks you guys use or anything you do? I hope there are no drug seekers out there listening. But
Bernardo, what do you think? I'll tell you what I do.
Okay.
Basically, a neurosurgeon told me this once. He said, opioids are not a big deal to give somebody if they've had traumatic penetrating injury that they're going to be better from in 2 weeks.
Right.
If you get stabbed with a knife, you're going to hurt. You can take opioids for 2 weeks, you're fine. Okay? But if you have chronic pain that's not getting better anytime soon, like you don't have a deadline for when you think that pain will be better, the last thing you do is add opioids to them because they'll just get drug resistant and it won't work. Back pain doesn't get taken care of all that well with opioids. You just get sleepy, you fall asleep, and then wake up and you hurt more. I don't give people opioids for back pain. And you do also want to very surreptitiously always check a straight leg raising sign. Because if you have a patient, you're distracted, and you look at the sole of their foot, and you act like you're looking at their foot, and in the meantime you've done a straight leg raising test, they have a negative straight leg raising test, the odds to a herniated disc in a patient with low back pain and no straight leg raising is about 1 in 4,000, according to the Handbook of Neurosurgery.
Wow, that's pretty reliable.
So I wouldn't give somebody opioids. And in this day and age, you don't need to give them opioids. They can buy opioids as an outpatient. It's no big deal. When I was in the VA once, I was gone for the weekend. I came in on a Monday. And my patient looked at me and goes, "Doc, man, I was hurting so bad on Saturday night I had to send out for drugs." They don't need to get them from you. Let them get them from somebody else.
Well, that's good. How about you, Bernardo? What do you say on that issue? Is there anything you do to test the real back pain from the feigned back pain?
Sorry, I didn't understand the question. Can you repeat
it? In the United States, it's a continuing problem, especially in the emergency room, where you have a patient that comes in with maybe a history of chronic back pain, like Richard said, not so much traumatic, and they want opioids.
Yes,
And is there any? It's probably a problem in Brazil too. But is there anything you do like Richard does the surreptitious leg raise? Is there anything that you do to kind of try to screen the patient by physical exam? And students, this is very important. You're going to see lots of back pain, and it helps to know these things.
We have this problem too, the people abusing of the opioids. But I avoid opioids in degenerative chronic pain because it doesn't work. Exactly. It doesn't work. I prefer some kinds of muscle relaxing and maybe some kinds of antidepressive and another drugs because the opioids doesn't work for chronic pain. They became addicts of these kinds of drugs.
Okay. All you're doing is making junkies.
Yeah. Okay.
And another problem that we have in our country is we cannot get the patients out of the work. They continue to working hard on on constructions, on buildings and industries, and we can't give rest to the patients.
Really? You can't write an excuse?
The conservative treatment.
Okay.
I don't know if you could understand that.
I think he means, Richard, that you can't give an excuse, say, strict bed rest for 2 weeks. Is that what you mean, Bernardo? They can't give an excuse to a patient if they suffer if you think they suffer the acute back strain, say, with a negative MRI, negative X-ray. You can't write a note that says no work for a week or 2 weeks.
Yes, exactly.
What's your feelings on that, Richard? I guess every case is different, obviously.
No, not really. You know, in Florida, where we have so much in the way of immigration issues,
okay,
we have it because the people that come north from the south are incredibly great workers, and they work hard. And here we don't work, so we need somebody to do our work. You know, I mean, it's clear to me that, you know, they're just better workers, and I don't think they should have time off to have, like I said, bed rest. I don't want anybody to have bed rest. That's worse. But people have to go to work, and you know, I don't ever remember not going to work, and I've been doing neurosurgery for 20-something years, and I have back pain, and granted, I'm not a roofer anymore, but that's what motivated me to not be a roofer. I didn't want to have to come to work like that. So I think, you know, people from the south south of here just tend to be better workers.
Okay, well, that's interesting. Ben?
I just think that the industries should have some kind of program to prepare physically these kind of workers, like the kind of physical therapy and another kinds of program to avoid the excusing. You know?
No, I know what you're saying. I think there does have to be organized treatment for the people, but you know, I think that too many people just take advantage. I mean, we don't see self-employed farmers laying in bed for 2 weeks, neglecting, you know, his business. So, but there are people that have terrible pain and need help. But most people should be able to get adequate treatment without being, you know, permanently impaired.
Okay, Sajesh or Ben, do you have questions? You guys are quiet.
Hi, Richard. Thanks.
Go ahead, Ben.
Sorry.
Oh, I'm sorry, Sajeesh. I'm sorry, I got the wrong one.
Okay, yeah, that's that was a nice talk. Actually, yeah, you really don't want to see a back patient problem, a patient with back pain, and yeah, as you rightly said, surgery is not the way to go ahead. But I have one question here. When you do surgery for intractable back pain, is there a chance that you can make it worse? If so, what is a percentage you would?
First of all, for intractable low back pain, there's not an indication for it unless the indication is now a failed back surgery syndrome where they've been injured by the surgery. And then what you're doing is usually placing a spinal cord stimulator to try to alleviate their discomfort. But that's really the point, is that if you can't find a source for the pain that isn't tangible, a surgeon's really not going to help you very much. I mean, for a surgeon to help you, we've got to be able to identify the cause very specifically and to do something to sever the problem, whether it's sectioning of a nerve, overriding a nerve, lesioning the brain, lesioning the spine. You know, just back pain, we don't have a specific treatment, you know? Mm-hmm. We don't have something that provides a mechanism of action like in a drug that will decrease the pain.
Okay, Ben,
yeah,
do you
but the question was, can it get worse? You know, can you make it worse?
I think every time you do an operation like that, you make them worse.
Oh, okay.
I mean, definitely. Yeah, that's where you make a dural tear, they have a spinal fluid leak, they get an infection, they get one. Yeah, I mean, the best they're going to come out of that is not having lost any ground, right?
Yeah.
I'm certain. And in, you know, today's day and age, I will tell you in Florida, and I've come to believe it now, I think there's been so many sick people in hospitals, you know, for appropriate reasons, whether it's pneumonia, you know, infectious diseases, endocarditis, whatever. You really don't want to have an elective spine surgery in an OR that has a significant infection rate. It's almost like you prefer to have your surgery, if it's elective and appropriate, in a surgery center now. You don't, I mean, because the odds to getting an infection in a hospital are higher than as an outpatient.
Yeah, yeah, right. Thank you, Richard.
Well, yeah. you know, Richard, I see a lot of patients. I used to see a lot of patients in the ER, and I basically tell them, and most of the patients are pretty smart about it. They've spoken to friends that have had it, that didn't get better, that got worse, and as you know, most patients don't get better with back. That's my experience. Most patients that I've talked to don't get better with it, and like you said, the indications are too wide to have it, and then there should be more selective about the patients that should be operated on. It's a big problem in our society.
Yeah, it is huge.
Yeah, it's giant. Ben, do you have a question? Hello, Ben. Are you muted or you're? I think you're muted, Ben. Well, anyways, okay. Any more questions from the panel? Everybody, you all set, Bernardo?
May I ask another?
Is everything okay?
Yes.
Congratulations for the presentation.
Thank you.
Thank you, Bernardo. We'll talk to you later. Okay, Lisa, go ahead.
Thank you. So, on the causes of the thoracic pain, thank you for giving all those options. And I did hear you say that gallbladder disease is one of the causes. And I was wondering, if someone had gallbladder surgery, should that eliminate the back pain in the thoracic area?
I think it does, if I remember from general surgery right. I think you can get a presenting symptomatology of like an area of pain underneath the right scapula from just gallbladder disease. I think it does get better, but It's been a long time since I was an intern. So, but you just have to keep your eyes open with thoracic pain and really think through things like, you know, the guy that was having all that chest pain after a heart transplant, the one thing you know it's not is his heart. It's not connected. That's the one thing it isn't. So, you know, just it's when you miss something, it's because you usually overlook something.
Mm-hmm.
You know?
That brings us way back to the days of embryology, Lisa, of referred pain from the diaphragm, irritation of the diaphragm. You remember how some people get, and Richard, I'm sure you remember, you get pain in the shoulder sometimes from gallbladder problems.
Yeah.
It's because of referred pain from the embryological development of certain organs. So, Ben, do you have any questions? Oh, you're all set. I guess your audio must be out. Okay, Richard, I thank you very much for another clear, good presentation.
What do you want to do next week?
Well, any requests there from the panel? Bernardo? Anything you want to hear about particularly? Anybody? Simon? Ben? Sajeesh?
Well, if somebody thinks of something, they could
I'd
just
like to see
email
some
me.
pictures of the surgeries.
You want to see some surgical? Okay.
I'd
Well,
like to see the.
Yeah,
Yeah.
we'll discuss it, Richard. We'll send you some requests.
Okay.
So that's great. Thank you very much, Richard, for coming out, and thank you for all the panel for attending. And we'll see you next week at 2 o'clock. Good
Okay.
day. Thank you.
All right. Thank you.